Thinking Rare. Because every rare kidney disease in children deserves deeper thinking. Thinking Rare is a podcast by ESPN, the European Society for Pediatric Nephrology. This content is designed to inform and support clinical learning, not to replace professional medical advice. Please consult a healthcare professional for personal health decisions.
Hi, my name is Garrelfs. In the second episode, we continue exploring the clinical thinking behind rare kidney diseases in children. Today, we focus on primary hyperoxaluria type 1, or PH1, a rare genetic disorder that can cause progressive kidney damage and systemic oxalate accumulation. In the second episode, we will discuss the therapeutic strategies and clinical presentation of our youngest patients. Today, I'm joined by a colleague who brings valuable experience and insight to this complex topic. Here with us today, Professor Licia Peruzzi, a pediatric nephrologist and head of the pediatric transplantation program in Turin, Italy. Welcome, Licia. How are you today?
Hi, hello, Sandy. Nice to be here with you, and we'll try to discuss a little bit while during the coffee break.
So, while preparing this podcast, I've read your impressive career background, and I just want to ask you: do you still remember the first patient that you diagnosed with this disease?
Well, I remember very well because my career started a long time ago, and the first diagnosis was an incidental diagnosis after a transplant, a failed liver transplant in a girl which was adopted after a quite complex social story. She was about 8 to 10 years old, and she passed a lot from institution to institution, and was finally adopted, and she had a renal failure for unknown reasons. At those days, nephrocalcinosis was not further investigatable. I mean, we didn't have any genetic assay to describe further, and so she was addressed to a kidney transplant because she was on hemodialysis in our unit. And immediately after transplant, the kidney never worked, so she was biopsied, considering the risk for a rejection or ATN. And we surprisingly found that the kidney was flooded by crystals that were described as oxalate. We had some expertise here in Turin in stones, in kidney stones, and this disease was, I mean, discussed together with the people expert in stones that addressed us to the suspicion of primary hyperoxaluria. So she had a very complex clinical course with multiple organ failure, and then with a rescue liver transplant was attempted, but at the end the girl died of complications of the liver transplant. So this story really astonished me a lot, and I must admit that still today, um, about 30% of the patients which are on the waiting list, on the active waiting list, meaning spanning from adults, I would say, but also some children, do not know the reason why they have renal failure. So today, at least in children, we try to have a precise diagnosis for every child.
The severity of their cases are really illustrative of the severity of the disease, at least when they develop systemic oxalosis at such a young age. Maybe we should discuss the case that you've recently published last year, and that's really highlighting the developments that we've had the past decade. Could you maybe just introduce that specific case shortly?
Yes. So this was a family that had the same initial story as I told you about the others. So the first alive child, because they already they had 2 or 3 spontaneous abortion. Then this child was born. Apparently everything was normal. Then at 2 months, he came to another hospital for vomit and intercurrent. Nothing serious, but and he was sent home with just something like supportive. Mother was
Mm.
not convinced. She came to our department, to our emergency department, and they performed examination. and he had end stage renal failure. So they performed all the examinations and they called me. I remember perfectly, it was July, and they sent me by WhatsApp the images of they performed x-ray of the thorax because it was not reading that well, and they caught also the kidneys in there, which was two stones, two chalked in the x-ray film of the thorax. So at those days, we didn't have any drug available or any new drug available, and so we started intensive dialysis, and then we did this combined hemo and PD. That
Yeah.
had many problems. We performed a liver kidney transplant when he was just about 1 year old. Everything went well. We performed CRT for 1 week and everything seemed to go well. Then after 1 month, he had respiratory infection, and he went to intensive care because of respiratory failure. And the anesthesiology wanted him to be very dry as always. And in that situation, he lost the kidney graft. There was nothing we could do.
Yeah.
So he remained with a liver graft, but on dialysis again.
Yeah.
And we had 2 or 3 years, where in 2 or 3 years on dialysis, because he went from a problem to another, and so we couldn't wait list him rapidly. When he was finally transplanted, he had everything was had in the vascular situation was very bad because of the repeated access, and so we performed a kidney transplant on the spleen. And then after that, he also had seizures and everything. So when the mother came and told me that the pregnancy test was positive, I had that heart attack because after everything we saw in those years, and she was really afraid. But fortunately, when she came, I told her maybe we can have a possibility, and so
Yeah.
we told I told her let's do everything we can, and we have just started to have the compassionate availability of lumasiran for another child.
Yeah.
And so I told her maybe we can have access to the drug, but first let's make a diagnosis. Let's hope he's not affected, and
Yeah.
let's
Yeah.
try to make the diagnosis on the villus as early as possible. And unfortunately, the child was the same homozygosly affected as his brother, his older brother.
Yeah.
So we decided to follow the pregnancy systematically. We assessed also the blood oxalate in mother, the blood urine oxalate in mother, and then we had some amniotic fluid sample,
Yeah.
and they were all normal. And so I decided that I didn't want to experience the risk of the physiological renal failure in the first days of life. So I decided to anticipate the treatment of this child as soon as possible. So I arranged everything to plan the delivery, because mother also had the gestational diabetes, so the fetus was huge. We stabilized the child, cannulated the child, and decided to administer lumasiran at 6 hours. I was astonished when I got all the results, because at 6 hours, blood oxalates, even though we were able to hydrate the child and he didn't lose even a gram of weight, but oxalate were increasing very steeply.
Yeah.
We administered lumasiran at 6 hours for the first dose. We cannulated the child, overhydrated the child to avoid the physiological decrease and physiological dehydration.
Mhm.
But still, I was really worried when I when I saw that oxalate in blood kept increasing until 15 days, which was expected. But when you see that blood oxalate goes over 100, and you know that the saturation is probably 50, and it goes over
Yeah.
100 and something, you're really worried. So the child was hospitalized for more than 15 days, because we kept overhydrating him
Yeah.
both intravenously and orally. I was following the ordinary schedule But at 6 months, it was 10 kilos. And so we had to decrease the dosage as expected. And we saw that glycolate and oxalate and glycolate started to decrease after 3 doses. So after 2 months, we had some spots, hyperechogenic spots at ultrasound, but fortunately we were able not to see any nephrocalcinosis. The child now is 3.5 years old, and he has perfectly normal renal function, no depositions at all. Is continuing the therapy.
Yeah.
And I think that and he's doing really well compared to his brother. We did a good job.
That's a really nice illustration of a successful case, of course, of an antenatal diagnosed child within a family that are known with early onset PH1, of course. And then, of course, because this is really important for newborn screening, there's this recent article, of course, from the German group that did a pilot using genomic screening, but only for one variant, and later also biochemical screening for both PH1 and 3. What is your opinion about using newborn screening to diagnose PH1?
I'm in great favor because the population living in our country and in our city, in our big cities like mine, are very mixed. In general, in the city, 30% of the newborns come from foreigners, and they are mostly from North Africa, where they have a high risk population because of high tax of consanguinity. I think this is worse because we have a therapy, and we experience a very bad infantile oxalosis. And even if you spare one child every 2 years, I think it's a great advantage for the family, for the person, and for the community, because the costs related to liver and kidney transplant and repeated kidney transplants and immunosuppression and everything are costs that completely balance the cost of the screening for this disease.
So you would advocate for newborn screening, but we are still searching for the best way possible, right, to diagnose patients as early as possible. Biochemical assays would be an option, but of course, genomic screening would also be an option, but it might be more costly to do that.
Biochemical screening, probably, if we can achieve that, will be more extensible, more rapid, and included in other screening programs. Will be done on blood, and I guess that on blood in the first 72 hours will be informative enough. Then the positive cases will be sent to genomic screening rapidly, and we'll decide. But anyway, if you get a very high oxalate level, I would even consider to treat. It is also written in the guidelines. You can even treat while waiting for the results, because it's a train that you lose. I'm afraid that we lose the train if we wait for all the confirmation.
Yeah.
And of course, the drug is expensive, but even to have all renal failure in a newborn is very expensive.
Maybe for the listeners, since you have such a broad experience in this field, can you give some advice on the other therapeutic modalities like dialysis that we have to at least reduce the amount of oxalate and hopefully, take a hold of the systemic oxalate deposition in these patients? So, of course, we can now start RNAi. What else can we do?
One point which demonstrated to be very, very important and even more effective than any dialysis system, any dialysis modality, is try to keep some diuresis. So the oxalate amount that can be removed by spontaneous urine, spontaneous diuresis, is much more than you can perform with even the best dialysis system you can perform in a small child.
During the first episode, I discussed transplantation strategies with Dr. Hayes. But in such a young child with infantile oxalosis and severe systemic oxalosis, how do you monitor therapeutic efficacy after starting both dialysis and also the RNAi therapy? And when do you decide that it's safe enough to go, for example, for a kidney alone transplantation in this difficult group?
I must admit that we are a medium volume center. The last 3 children we diagnosed were small children, and so that they were treated immediately before they had renal failure and before they had nephrocalcinosis, and so they don't have developed any renal failure, and the plasma oxalate are normal and urine oxalate are normal under the therapy. But
Yeah.
they were fortunately precocious diagnosis.
So,
Yeah.
Licia, I think we really had a nice conversation, and during this episode, I think you've nicely illustrated the severity of this disease, but also the importance of early detection. Thank you very much for Licia for this nice conversation.
Thank you to you.
Thank you for listening to Thinking Rare, a podcast by the European Society for Pediatric Nephrology. Join us in the next episode as we continue exploring the clinical thinking behind rare kidney diseases in children.
This was Thinking Rare, the ESPN podcast on rare kidney diseases in children. This episode has the unconditional support of Alnylam. For more educational resources and upcoming episodes, follow us on the ESPN channels and visit www.espn-online.org.